Welcome to Your Aged Care Compass podcast. Join us to find out how to support your older loved ones at home. We're going to help you make sense of Australia's aged care system. We talk about legal and financial considerations for ageing and how chronic health conditions impact your older loved ones' well-being. And we share real-life stories of where it went wrong for people and how we got them back on track.
Hello everyone, and welcome to today's episode, Bringing Dad Home from Hospital. I'm Michelle, and I'm really pleased you've joined us today. For the past couple of weeks, we've been talking about how our dad was diagnosed with Alzheimer's disease and what happened afterwards. During Dad's last year with us, which was 2017, he had 4 strokes as well, being hospitalised each time. Coral spoke about this in last week's episode, describing the delirium Dad developed after each stroke. Dad recovered quite well after the first 3 strokes in 2017, but the 4th stroke didn't see him recover as well, and this stroke left him with significant functional deficits. Today, we're going to be talking about how we brought Dad home from hospital after that 4th stroke. His needs were high and he required a lot of support. Coincidentally, you've just been over here in Perth, Coral, speaking at the Carers WA conference, your presentation discussing Dad's story too. Acknowledging all the carers who have tuned in today and are listening to this episode, we just want to say thank you and let you know how amazing you are. It can be so isolating and exhausting being a carer. But when asked, carers always say that they wouldn't change anything, that it is a privilege to care for a loved one. And as we promised our friends Michelle and Catherine of Home Instead, who we caught up with at the conference, we'd give them a shout out on our next episode. So, hello Michelle and Catherine. Coral, during last week's episode, you spoke about the hospital admissions Dad had for his knee surgery and then after the strokes and how he developed delirium each time. The functional deficits that resulted from the strokes meant that Dad not only had to recover from the delirium, but he had to regain enough function to be able to be discharged home from hospital. After the 4th stroke, it might have appeared that Dad's options were limited, given he had lost significant functional ability and needed 2 people to help with his activities of daily living. Talk us through that hospital admission for the 4th stroke, Coral.
So Dad had already had 3 previous strokes during 2017, Shell, and they all presented pretty much the same. He had a sudden loss of speech, he developed a facial droop, and he suddenly became weak on his left side and wasn't able to support his own weight. When Dad exhibited these signs again in August 2017, Mum called 000 right away. And then she called us and we all headed into the hospital. In the emergency department, Dad was seen straight away, as we know treating a stroke within the first few hours from onset of symptoms will give the person the best chance of recovery should the stroke be from a clot. At the time of presentation, no one knew, of course, if the stroke had been caused from a clot or a bleed. So while all the investigations were happening and all the conversations happening around us, Dad was trying to communicate, but he couldn't. He couldn't talk. So we had to try and work out what he was trying to say and relay that to the doctors and nurses. He also couldn't stand by himself, so he couldn't be taken to the toilet, and he couldn't have anything to drink as his swallow reflex was impaired too. I remember just looking at his face and feeling his desperation and confusion and realising how completely disempowering the situation was for him.
Yep. What happened next, Coral?
He was transferred to the stroke unit, Shell, and he was placed in a 4-bedded room near the nurses' station for acute strokes. It was a busy room with 3 other acute stroke patients, and nurses were continually coming in and out monitoring these patients. As I mentioned last week, Dad developed delirium after each stroke. I had alerted the nurses that I wanted to stay, but in the acute room, there wasn't any room for me with all the monitors and equipment.
Yep.
So we negotiated. The nurses moved Dad into a single room, which was still close to their station, and brought me a recliner chair. I stayed with Dad and attempted to keep him calm and settled, and of course, being a nurse, could identify any deterioration and notify the nurses should this happen.
Coral, were the nurses appreciative of this?
Yeah, they really were. They really were, Shell. And look, I understand that I'm in a bit of a unique position because I'm a nurse, that I had that knowledge of stroke
Yeah.
and deterioration and could easily alert them if something wasn't quite right. And there was some apprehension, and they did have to speak to the doctor about, was it okay taking Dad from the acute stroke bay or the room and putting him in a single room because, they wanted to monitor him. So there was some conversation, but I think because I had that clinical knowledge, the doctor and then the nurses were comfortable with doing it. But with Dad being so restless and agitated and having that delirium, they accepted that I was actually helping them out by staying with Dad.
I guess that's why I asked you, because I feel that in terms of their already overburdened workload,
Yeah.
this would have made a big difference to them.
Yeah. Yeah.
And then the family roster with Mum and Sandy began, and you tried to ensure someone with Dad as much as possible.
Yeah, the nurses were just so busy. Like, they're always busy. And I knew if no one was, with Dad, he'd climb over the side rails of the bed and crash onto the floor. He was that restless.
Yep. So what did the following days look like then?
Well, they were very busy days with his doctors reviewing him and the physiotherapist, occupational therapist, and the speech pathologist assessing him. He was paralysed on his left side, so he needed a lot of help with all his personal care, his transfers, and his mobility. He was wheelchair dependent at this time. He was also on a texture-modified diet due to his swallow reflex being impaired, so he needed help to eat as well. Like I just said, he was very agitated initially, but that did begin to resolve during the time he was in hospital. So that as he began to settle, we were able to pop him in a wheelchair and take him outside. He still couldn't communicate, so it was really difficult for him to express his needs and for us to understand what he was trying to convey. He wasn't making much progress with regaining his function, and I knew there was a conversation looming about Dad's discharge plan. I knew what the conversation was likely to be, as I'd seen it so many times with other families in this position over the many years that I worked in the hospital. I knew that the treating team were thinking that Dad's care was too high to be taken home by us. And I anticipated that they were going to suggest transfer to residential accommodation or a nursing home directly from hospital.
And that was the one thing that Dad never, ever wanted.
No, he didn't want that, Shell. And
No.
look, we didn't want that as well. By this time, Dad's dementia was so advanced that I honestly believe it would have been catastrophic if he had moved from hospital to residential care. He was so severely cognitively impaired. And, after these strokes, the impact on his ability to do anything for himself, he just couldn't. And I knew that, it just wasn't an option for us.
Definitely not.
Yeah.
So what did you do?
So I initiated this conversation with my colleagues.
Yep.
I explained to Dad's doctors and the physiotherapist and the occupational therapist that we could manage Dad's care at home. And I asked them to support us. Specifically, I asked for the treating team to refer Dad to the transition care program.
So explain to our listeners what the transition care program is, Coral.
So Transition Care Program, or TCP, is one of the Commonwealth-funded aged care programs, under the broader aged care program, and it comes under the flexible care aspect of that broader program. Being one of the aged care programs that's funded by the Commonwealth, this program, TCP, is available to anyone discharging from a public or a private hospital across Australia.
Right.
TCP is a 12-week program of clinical support to assist people moving from the hospital back home after a health event that has caused them to lose their function and independence. It's kind of like a rehab program in your own home. So based on what your needs are, if you're approved to go home on transition care program, you'll have a team of clinicians, might be a physiotherapist, might be a dietitian or a speech pathologist, could be an occupational therapist, could be a nurse, social work. Any number of those clinicians that are working within TCP will come and visit you at home to help you regain your function.
Right. How did Dad's treating team respond to your request?
Well, they were sceptical, and I knew that they would be sceptical. They were apprehensive that we could manage Dad's care at home, even with him being on TCP. But they agreed to make the referral, and the TCP team came to assess Dad in hospital.
So Dad was approved to go home on TCP, but he also had a level 4 home care package. Did that cause a problem, the fact that he already had a home care package?
No, it didn't. So having a home care package is not an exclusion criteria for TCP. Dad was able to keep his home care package, but it was paused while he was on the 12-week TCP program.
FlexiCare is a not-for-profit organisation which supports older people living in Brisbane's southern suburbs to live their best lives in their own homes and communities. FlexiCare don't have grand plans to be the biggest aged care provider. They want to be known for treating each one of their participants as an individual who they get to know well. They answer their phone calls personally when clients ring them. They give their clients easy access to a home care partner who can work with them to deliver the best mix of support possible. If you're in Brisbane South and want to know more, give their friendly team a call on 07 3422 8400 or check out their website flexi.org.au. But Coral, we hear that some people are denied TCP because they are on a high-level home care package. Can you explain this, please?
Yes, look, unfortunately, this is something we hear. Like I said, having a home care package, even a high-level package such as a level 4, doesn't exclude people from this program. But some TCP teams feel that if the person has a high-level package, that they should be using their home care package funding to support their needs, even after an event as significant as a stroke.
Yep.
But Dad's home care package funding was already maximised as his needs were already so high. So there wasn't any funding to draw upon from his package. I explained this to the TCP team, and look, I was assertive in my conversation about Dad not going into residential accommodation, that we were going to take him home, and it was my expectation that we should be supported to do this.
Absolutely. And look, I remember this time well, as this is when you called on me to come over and help with the move for Dad from hospital back to home. And listeners, just so you know, yes, I felt incredibly guilty a lot of the time that I wasn't there helping more, but it was unwritten, and it really was a case of if things got too much, I got a phone call and I was on the next plane over.
I think what you've just said, Shell, raises something. It's an important consideration for the families to reflect on and consider because, we were in a privileged position. Before coming to work for me, you were a pharmacist, so you had a lot of clinical insight as well, me being a nurse and working in that space. And then our younger sister, Sandra, who lives here as well, was able to assist. And then, our brother, Alan, who lives in Sydney, was there to call upon if needed as well. But it takes a village. It was a big undertaking. So when I talk about this story, it's not with the suggestion or the expectation that it was an easy thing to do or it's achievable for other families as well. It was a big undertaking, but at the same time, if a family wants to do this for their older loved one, they should be supported to do it. And, at that time, I had been the ACAT assessor in the hospital. So what that meant was my role as the ACAT assessor was to step in when there were situations like this, when the treating team said, you can't take mum or dad home, or you can't take your wife home because her needs are too high. She has to move into residential care. And this was so distressing for so many families. And as the ACAT assessor, assessing people in the hospital, a person can't move into residential care without having that approval from the ACAT. So sometimes I would go in and it wasn't a given. When the medical team called me to do these assessments, I wouldn't go in and just go, yep, sure, you're going into the nursing home. Let me do my assessment and tick the box. I did speak to the family and I wanted to make sure that that's what they really wanted. Because, as people who are familiar with my story know, this was one of the reasons why I left my job in the public health system and launched Seeming Aged Care Navigators, is because my wonderful colleagues in the hospital didn't know how the aged care system worked. And so they weren't aware what was achievable with a person going home. So sometimes the default was they needed too much care, they had to go into a nursing home. But families were putting up their hands and saying, we want to give it a go. We want to take mum or dad home and just see how it goes. And I firmly believed then, and I do now, that people should be given the opportunity to do that. So when I was called into those situations previously, we'd have that conversation and I would actually go back to the treating team and say, I'm not going to do this assessment. I'm not going to approve a person to go into residential care because they want to take their loved one home. And this is how we're going to do it. So giving them the solutions, giving them the education, talking them through and showing them what was achievable rather than just saying, yep, no, sorry, mum's not going to come home. We're going to put her in accommodation.
Yeah. And that's, in that situation, it's not the family's decision. And the family should be given that decision.
Yes, they absolutely should, Shell. Like we've said, this was a big undertaking for Dad and not everybody can do it. But those that want to do it should be shown how they can achieve it.
Yep. Yep. And Coral, I remember when we brought Dad home and he was still in a wheelchair at that stage. And just after he arrived home, he wanted to get out of the wheelchair and sit in his recliner chair. So we both helped him to stand and to transfer. Do you remember what we said?
I sure do, Shell. I remember we just looked at each other and you said, what have we done?
Yep. He just couldn't bear weight. He was in dead weight.
I know. And I remember second guessing myself at that point. But you know me, I'm determined. So there was no way we weren't going to make it work. And I could see, I knew that Dad was determined as well. And I could see the possibility. And he had the previous 3 strokes, he had bounced back from really well. So me being the optimist, I knew that we could make it work.
Yeah. The thing I remember from that time as well, regardless of the fact that he was well down his dementia journey, every time I arrived in Cairns, I could see that spark of recognition in his eyes.
Yes.
And to me, that was worth everything.
Yep.
He knew who I was. He knew where he was.
Yes.
And I think the whole idea of him feeling safe in the surroundings that he knew to be familiar was the most important thing.
Oh, honestly, Shell, you're absolutely right. It made such a difference. It was really quite remarkable, He did, we discussed, he developed a delirium after this stroke as well, but that resolved after we got him home and he was so much more settled at home.
So we had the physiotherapist and the allied health assistant prescribing exercises for Dad. The occupational therapist had recommended some equipment, which we purchased, And the speech pathologist checked on him and reviewed his gag reflex to establish if he could start on a normal diet again. He didn't like the thickened fluids, did he?
No, he didn't. And sometimes I'd let him have a few sips of unthickened water.
Yep.
I sat him upright, I made sure he wasn't distracted, and I gave him small sips at a time. I told the speech pathologist who I knew and worked with, and she gave me this look and she said she'd prefer not to know. But it was about Dad's quality of life. I knew his dementia was catching up with him, and after this stroke, I knew we were moving towards his end of life. So those small moments of having a sip of normal water felt like the right thing to do.
Yep. And remarkably, he didn't ever inhale the water. He did not get aspiration pneumonia, did he?
No, he didn't, Shell.
No. So Dad concluded his 12-week TCP program and his home care package recommenced. Then what happened?
Well, Dad, as you know, had always been active. He was an accomplished sportsman all his life. So keeping him active wasn't that difficult, even though his dementia was advanced by this stage. His carers supervised and assisted him with ongoing exercise each day, and gradually he became strong enough to walk again. And he walked independently as well. I mean, using a mobility aid just was not an option because his dementia had advanced he was so cognitively impaired, he wouldn't remember to use a mobility aid and, he just refused to use it. So remarkably, he did manage to learn to walk independently again. Keeping him awake, as I mentioned last week, was important so that he slept at night. And of course, we took him on those daily car drives to manage the sundowning.
Yeah. And you mentioned earlier that Dad had a level 4 home care package, Coral. Did this provide enough funding to meet Dad's high needs?
No, it didn't even come close, Shell, to providing the amount of support that Dad needed. By this time, we had changed the services that Dad was receiving to be all carer support.
Yep.
But we had to supplement that care that Dad was receiving from his package by paying a private carer too. I remember for a period of time, we were paying a private carer $600 a week, which was beyond our ability to pay ongoing. And I did manage to get that down to $400 a week by stepping in ourselves to provide that care. But that level of care that we need, the level 4 funding, as I said, it didn't come close. So to be able to keep Dad at home, we had to be resourceful and look at what else we were able to do.
Yeah. And look, we were lucky. We had a little kitty of money set aside for a rainy day. So we were able to do this. But not everyone is in a position to do this, and then their options are limited.
Yeah, you're right, Shell. I know that if we didn't have that rainy day kitty, nor the family support that we had, that Dad would have had to have moved into residential care.
Yeah. So I'd returned home by this time, and you and Sandy kept supporting Mum and helped Mum to care for Dad. But eventually he became so weak and mostly bedbound, which was during his last days, that I hopped on a plane and came back again. And Coral, I'll never forget that. Those photos you sent from Christmas 2017.
Yep.
And I looked at those photos and I knew in my heart that Dad didn't have long.
Mm. Yeah.
It's another big part of Dad's story, his end of life. I think we'll hold that over for next week, that part of the story. Supporting Dad to die at home was something you've been asked about a lot, Coral. So we'll conclude today's episode here and meet you back on the podcast next Tuesday to talk about how we supported Dad to die at home. Thanks for tuning in today, listeners. Coral is often asked about taking older loved ones home from hospital. In fact, it's one of the reasons many people book a Let's Talk consultation with Coral. When people are told their loved one can't go home from hospital, that their care is too high and they need to be moved into residential care, it may not be the case. It is possible to take an older person home when their care is high, as we've discussed today. It's not an easy undertaking, as we know only too well. But if you're resourceful and determined and can access aged care programs to support you, then you should be supported by the hospital to do so. We look forward to you joining us again next week. Until then, take care. Hey Care community, thanks for listening to this episode. So you never miss a show, make sure you subscribe to our podcast. If you'd like to know more about what we do, head to our website, cmeacn.com.au.